The Lachman test shows excessive movement of the tibia forward in relation to the femur. The anterior drawer test also confirms this. A pivot shift test is done with the knee flexed and rotated. This shows the tibia sliding quickly in relation to the femur, also confirming a torn ACL. This patient has elected a hamstring graft for their ACL reconstruction. A small incision is made along the top of the tibia where the hamstring tendons attach. The semitendinosus and gracilis tendons are identified. The gracilis is on top and the semitendinosus on the bottom. We release these tendons from their fascial bands attached to the surrounding muscles. The tendons are then separated and they're harvested with a tendon stripper. The tendon stripper is inserted and will be used to release the tendons from their muscle attachment sites. There's a little muscle that comes off with each tendon, and this muscle will be removed later. The second tendon is harvested. The incision used is quite small and is also used to create the tibial tunnel. The two tendons are looped to create a four-stranded graft. Suture is placed on either end of the graft to compact it and to create one unit. Arthroscopy is performed to evaluate the entire knee. The torn ACL is confirmed. The posterior cruciate ligament is next to it and is found to be normal. The intercondylar notch is that area of the knee where both ligaments are found. The remnant of the ACL is removed. This clears the way for the ACL graft. A small amount of bone in the notch is removed as well. This allows for accurate placement of the femoral tunnel. The site for placement of the femoral tunnel is determined and marked. Tunnel placement is critical for successful ACL reconstruction. Once the site is marked, a drill is used to create a pilot hole for the ACL femoral tunnel. A guide pin is placed in this femoral tunnel. And this guide pin is over-reamed with a reamer chosen based on the size of the ACL graft. This is reamed to the appropriate depth. I like to compact the bone in the tunnels with the dilator. I think this allows for better purchase of the screw that will be used to hold the ACL graft in the tunnel while it heals. The front of the tunnel is notched to create a pilot hole for later screw placement. The femoral tunnel is as far back in the notch as possible. A guide is placed on the tibia for guide pin placement, and the process is repeated with reaming and dilating the tibial tunnel. Once both tunnels are created, a passing suture is placed, and this will be used to pull the ACL graft up into the tunnels. The ACL graft is placed into the tibial tunnel and is then pulled up into the femoral tunnel. The femoral side of the graft is then fixed with a bioabsorbable screw placed in front of the graft. And this squeezes the ACL graft firmly against the bone in the tunnel. The same thing is done with a bioabsorbable screw on the tibial side of the graft. Once the ACL graft is fixed on both sides, it is tested for stability, and this is found to be excellent. The knee is then taken through a range of motion to make sure there's no impingement of the notch onto the graft with the knee fully extended. Lockman and anterior drawer tests are assessed, and this shows a stable knee. The incisions are closed, and this completes the ACL reconstruction.